Good morning, good afternoon, good evening, everyone. It's Tuesday, it's Neurology Morning Report. So nice to see everyone and looking forward to discussing a neurology case. So wondering if anyone brought a case today that they wanted to present, and then two people to discuss that case with me, ideally one identifying as a woman and one identifying as a man, if possible. Do we have any volunteers? Anyone bring a case they wanted to discuss? Neurology case. No neurology cases. Rafa's trying to drum up some excitement. Who would like to discuss a case today? We'll have a case just in case if no one brought one. But
I discussed last week. I can be discussing if no one.
Fantastic! Look at that enthusiasm. Someone who's done it before is eager to do it again. We'd be happy to have you, John, but always great to have new people as well. Vijay, you have a case. Fantastic. And John, we'll have you kind of on deck here just in case. Do we have two discussants? You can have discussed before or not, but going once, going twice. All right, Vijay and John, why don't you introduce yourselves? I'm sure that will inspire someone to want to join in. And if people need further encouragement, although I'm usually like to talk a lot about neurology and we sometimes run over, I really have to be somewhere at 10 today. So if you'll join earlier and we can start earlier, that will give us more time for teaching because I'll have a hard stop a few minutes before. In the meantime, Vijay, John, why don't you introduce yourself? Tell us where you're from and where you are in your training, and I'm sure someone will be inspired to complete the trio here.
Sure. My name is John Acquaviva. I am from Lake Erie College of Osteopathic Medicine in Erie, Pennsylvania. I'm a third year and will be applying to neurology next year, and you guys should join the discussion.
Woohoo! All right, future neurologist is excellent, but not a requirement. So this is neurology for all is the goal here. Great, Vijay, have you introduced yourself? And hopefully someone will then be inspired by you both.
Hello, everyone. This is Vijay. I'm a third-year medicine resident from Bangalore, India. Neurology, like always, it has not been a very smooth understanding. So it was exciting and a safe place to understand neurology. So I presented 2 weeks back and I was a discussant. So thought I'd share an interesting case that I'd seen.
Fantastic. Thank you, Vijay, for those inspiring words. We're excited to hear your case and we had fun discussing with you a few weeks ago. Who would like to discuss with John and me a case from Bangalore, India? I'm excited. Somebody would like to discuss. People are thinking maybe this week, maybe next week. I'm actually, the next 2 weeks I'm on service. There won't be Neuro VMR. This is the week to do it. Otherwise we're until March, I think. Please help me get to my meeting on time. It's a very important meeting at 10. Anyone? Valeria, all right, thank you. Brilliant. Introduce yourself, Valeria. As discussed many times, we have some veteran discussants. Hopefully they'll inspire others to see how much fun we have together and how much we get to learn together. Go ahead, Valeria.
Yeah, hi everyone, I'm Vale, I am from Lima, Peru, and I'm in my 5th year of medical school, so really excited to discuss. It's always an amazing learning experience with this group, so thank you for the opportunity. And I really encourage you to next time volunteer, it's really fun.
Fantastic, thank you for joining and thank you for promoting how much fun and how much learning we do. We know people are afraid of neurology. That's why there's that term neurophobia. We are here to try to reduce, if not end, neurophobia. So let's go ahead and get started on that. So Vijay, can you give us just the chief concern, chief complaint in as few words as possible, and we'll discuss that and then we'll hear the HPI.
This is a case of a 41-year-old gentleman presenting with left upper limb weakness.
41-year-old gentleman with left upper limb weakness. So Valeria, what's coming to mind for you when you hear that chief concern?
Yeah, so I think it's quite localizing a weakness. I would like to say maybe it's proximal or distal, and also if of the time course, of course, because I feel like, I mean, we can localize maybe to the motor cortex or going on forward through the motor pathway. But if it's sudden onset, of course, thinking about vascular causes, and as time goes on, like acute causes, like inflammatory causes, infectious causes as well, and then more chronic or subacute, like demyelinating diseases and maybe malignancy. But I feel like also, so we can go from the cortex all the way down. I think it would be less likely to find a very specific lesion, for example, in the internal capsule, just because all the fibers are concentrated. By going down, maybe to a plexus lesion or something in the nerve or the root, and then going down to the muscle and the neuromuscular junction as well. So amylopathy could also be possible. And in not only like neurological causes per se, like for example, and something occurring in the apex of the lung could compress, or something on the vasculature as well that could compress the nerve fibers that give the motor, the motor nerves in the specific lesion. I think that's where I'm at.
Brilliant, Valeria, fantastic discussion. So we always begin in neurology with trying to figure out the localization and then the time course. And Valeria gave us a phenomenal discussion of both of those, right? So when we're localizing weakness, we know we must be somewhere along the motor pathway, right? And Valeria walked us through that pathway. We start in the motor cortex, which is the precentral gyrus, the gyrus just anterior to the central sulcus, the most posterior gyrus of the frontal lobe. And then the axons run through the corona radiata, through the internal capsule, through the anterior brainstem, and then cross at the cervico-medullary junction to descend in the spinal cord. The ones we're interested in clinically in neurology descend in the lateral corticospinal tracts, and then synapse, in the case of the arm, in the cervical and upper thoracic spinal cord to lower motor neurons, which are the anterior horn cells, which come out, as Valeria told us, through ventral roots, through the brachial plexus, and then out through nerves to the neuromuscular junction to muscle. So when we have weakness, we have to think, where along this pathway could we be? And we'll obviously learn a lot more from the history in the exam, but Valeria got a good start here saying, well, it's left upper limb weakness. So as far as we know, if we're dealing with just the upper extremity, right? We could have a cortical lesion. Remember, the homunculus, the arm and hand represent a large sort of territory of that because we have so much fine motor control, particularly of the hand and fingers, right? So you could get a cortical lesion that could give you just the arm. The face area is right next to it, right? So it might think about face and arm, but maybe the patient is so weak in the arm, they didn't notice a little bit of facial weakness. Valeria traced us down through the internal capsule and said, well, their face, arm, and leg fibers are so close together to get one tiny lesion. Just getting the arm fibers is less likely. It's possible, it would have to be very small. Brainstem, pretty unlikely, right? Again, the fibers are very closely packed together. The cranial nerve nuclei are there. And then spinal cord, possible. Cervical lesion could do this. And when we have a monoplegia, we also have to consider more nuanced peripheral anatomy, right? If it's really the whole arm from shoulder to fingers, is this a plexus problem? If this is particular areas of weakness within one limb alone, is that a problem with particular roots or particular nerves, one particular root, one particular nerve, multiple roots, multiple nerves, polyradiculopathy, mononeuropathy, multiple mononeuropathies, plexopathy, so many opathies possible in the peripheral nervous system, right? And that will require a very detailed exam of the sensory and motor function of the hand and arm, because by seeing which areas might be weak or which areas might have sensory loss, if that's at play here, we can localize very precisely to one or more roots, one or more nerves, or the plexus. And then depending on where we are, Valeria told us we have to think about the time course. So if we're brain and sudden, hard not to think about a stroke, right? And once we're less sudden and more into acute, subacute, we could be thinking about infectious, inflammatory, neoplastic, all sorts of processes here. So excellent initial layout of the landscape for us, Valeria, of the pathway along which we'll be localizing. Some initial thoughts, if this is truly just the left arm, where we might start thinking about putting that, though we need a lot more information, and then wanting to know the time course. Wonderful. So I'm going to ask you, John, to discuss the HPI after Vijay tells us about it. So what are some questions on your mind as we hear the HPI? What are some things you're hoping to find out and why?
Well, I definitely want to make sure it's actual weakness from the arm. I mean, there could be coordination issues, and other things that could be thought of as weakness from the patient, but to us objectively is not necessarily weakness. So that's something I want to rule out. Some big questions I want to ask are other signs associated with this weakness, because that really can help localizing through that neuraxis, either systemically or other signs within the spinal cord or the plexus or anything like that. But otherwise, I think you guys hit on most of it. But yeah, I think that's all I got. Went through the localization, but definitely excited about the physical exam and anything else that could point us to maybe inflammation or trauma or a trapped nerve or anything like that could cause true weakness, specifically in the arm.
Fantastic. So exactly what we're going to want to tease apart in the history, first of all, is number one, is this weakness, right? Because a patient might report the symptom of weakness, but what they actually have is sensory loss that's making it hard to grip an object because they can't feel it, but the subjective perception is one of weakness. Or they could have clumsiness or ataxia, right? And describe it as weakness because just the hand and arm aren't doing sort of what they're supposed to do. And some people just feel a sense of weakness, right? What we call asthenia, which we all feel when we're tired, when we're sick, if people are anemic, et cetera. It'd be pretty atypical for that to be so focal in one limb, right? So that in addition to knowing this as neurology morning report, moves us probably more towards thinking true weakness, because when people have sort of asthenia, that's usually a more global process, right? And then you make the important point that the patient's chief concern, right, is weakness, but we'd want to know, is there also pain? Is there also sensory change, right? Whether that's negative symptoms such as numbness or positive symptoms such as tingling or neuropathic pain, whether there are any other systemic symptoms, whether there's weakness. One of the questions I always ask when a patient says they have weakness in one limb, is there weakness anywhere else, or even something subtle, right? There's a young patient, so they'll probably be pretty attuned to the state of their body. But some older patients will say, well, yeah, it's a little harder to get out of a chair, but I'm just getting older. Well, that's, you should still be able to get out of a chair even when you're older, and that would suggest proximal leg weakness that we might have missed, right? So great, fantastic questions to have in our minds as we hear this history, which will hopefully get us a little more sense of how to localize things, right? Or is this a true pure motor presentation, or are there sensory or other features, right? And is it truly limited to the left upper limb? Because that's also going to help us with our localization and know how to target our physical exam. Great. Okay, Vijay, tell us what you learned in the HPI for this patient.
This is a right-handed individual who initially noticed weakness of the ring and the little finger of the left arm. He noticed it while he had difficulty in changing gears of the vehicle, of the two-wheeler. After which he noticed some difficulty in buttoning and unbuttoning the shirt. This weakness gradually progressed such that he had difficulty in lifting objects from the ground. However, this was the extent. This whole weakness lasted for about 1 year, after which the weakness has remained static. There is also associated thinning of the arms that in the hand predominantly. And he says an unusual pattern of wasting such that he says this part of the hand, so this part of the hand, the medial side has been wasted up to the forearm. So that was the chief concern. 6 months after the noticing weakness, he has also noticed twitching in the same regions in the hand, as well as that has progressed to involve all the 4 limbs, the twitching, but he has not noticed any aggravating or relieving factors for the twitching. There is no relation to temperature, hot or cold. There is no sensory disturbances or cerebellar disturbances at the level of history, or any history suggestive of any cranial nerve involvement. There is no history of weakness in any other limb. No bowel or bladder involvement, or no sphincter disturbance. No history suggestive of any autonomic involvement. he also denies any systemic syndrome, like any complaints of fever, weight loss, or any rashes or joint pains. Past medical history, it's not significant. He's not on any medications, except that after the onset of weakness, he was not evaluated, but a local doctor said he could have a possible motor neuron disease. However, has not been evaluated since then, and this was the time when he was came to our hospital. Apart from that, his personal history, family history, social history have been normal. There is no allergies.
Fantastic. Excellent, detailed, and a very interesting presentation, Vijay. Thank you. So, John, what are you thinking now after you hear this history? What are some of the things that jump out, and how do they help you?
So initially, I was thinking about that weakness and in the pinky and ring finger. I was thinking, especially with the atrophy, hypothenar, and like hyperthenar atrophy, I was thinking like maybe a mononeuropathy of the ulnar nerve, pretty low, which can't really get my mind off until I think of the tingling makes sense, but the twitching in all you said twitching in all extremities. I think that doesn't make too much sense to me regarding the specific neuropathy, unless it's like a multiple neuropathies. I think we were talking about a possibility of ALS presenting in a way in the chat. We were saying that, but I don't think with the sensation loss, I don't think ALS commonly presents with sensory changes, if I'm not mistaken. And another question to ask is what do we mean by twitching? So that could be something that we assess in the physical exam, whether it could be a tremor, something that's been there for a long time that is just presenting now, or it could be enhancement of just the normal physiological tremor for some reason. So regarding like the twitching, I don't 100% know what it means yet. Something else that would come to mind, the possibility of underlying MS, except what was the age of the individual? Sorry, I didn't get that part.
I think 41, I think.
So, I mean, I guess it's possible, but it usually would be a little younger in the diagnosis and presentation. But yeah, definitely looking forward to the physical exam with this and want to see what that the twitching really means, and if it could be something like a neuropathy or plexopathy or anything that's associated with hypothenar eminence atrophy and the weakness in the two low fingers.
Yeah, great thoughts, John. Quick clarification, Vijay, I had one of the same questions you had, John. Was there tingling, did you say at some point, Vijay, or no sensory change?
He had twitching. He didn't have any tingling. He just had twitching in the same region of the waist.
Twitching, but no tingling.
Sorry, I thought I heard.
Yeah, I thought I heard. That's okay. Yeah, I was listening for it too. Maybe we both interpolated it, expecting. Right. This is an anchoring bias, right? We heard these two fingers. We thought ulnar and neuropathy. There's always tingling there, so we both either imagined it there or wondered if it would be there. Very good. So let's talk a little bit about ulnar neuropathy, right? So. We don't have time to get into all the wonderful things we can teach about the upper extremity, but if you've had to memorize the brachial plexus, it's incredibly complicated. And most of what you need to know as a neurologist, but certainly as an internist or non-neurologist, is just the 5 main nerves to the upper extremity, which are the musculocutaneous, axillary, radial, median, and ulnar. The musculocutaneous does the biceps muscle, right? That's easy to remember. Making a muscle, right, is biceps, so it's musculocutaneous. The axillary does the deltoid, which elevates the arm, as well as the teres minor. It's very rare to get a musculocutaneous or axillary neuropathy because these are very short nerves off the plexus to nerves that are innervating muscles of the upper arm. So very rare to see those. And if you see one of those affected and there's no obvious trauma or something like that, you want to think about something very proximal in the plexus or roots. The radial nerve innervates a lot of muscles, but you can remember the mnemonic radial nerve is the best, B-E-S-T, where B is brachioradialis, E is the extensors of the wrist, fingers and thumb. S is the supinator, and T is the triceps. There's extensor carpi this, and extensor indices this, and all that. But just brachioradialis extensors, supinator, and triceps, which is also an extensor. And then median and ulnar get more complicated because the hand is so intricate, right? But the big picture is that the median is doing the lateral part of the hand and wrist. So first two fingers, the thumb is complicated. And then the ulnar is doing the medial. And lateral and medial on the arm are like from the Leonardo da Vinci painting, where the arms are like this and the thumbs are out and the pinkies are in. So even though median is doing the thumb side of the hand, that's the lateral part of the hand, unfortunately. So if you have to guess, median is thumb side and ulnar is pinky side. So flexor carpi radialis, median, flexor carpi ulnaris, ulnar. Flexor, the lumbricals 1 and 2, median, 3 and 4, ulnar. Flexor digitorum profundus 1 and 2, I can't bend them by themselves, but your most distal flexing is median, 3 and 4 is ulnar, and then breaking the pattern, flexor digitorum superficialis to flex at the PIP is median. I had to go through this a million times to remember it, but keep practicing it. Median, ulnar, and then all median, median, ulnar. So all median in the middle is how I remember that. Then the thumb extension is radial, right? That's our E in best. Abduction is median, and then adduction is ulnar, and opposition is median. So I don't think we've ever talked about that, but it took me so many times reading about it to figure it out that I developed that simple way and wanted to squeeze it in. So what would make you think of an ulnar? Oh, I forgot to mention also the abductors and adductors of the fingers are ulnar, the interossei. That's important because actually the ulnar neuropathy tends to feel more disabling for the patients because most median innervated muscles are, the long flexors are innervated in the forearm, and median neuropathy tends to be carpal tunnel at the wrist, right? So the only muscle usually involved is abductor pollicis brevis, which you need, but not as much as if you could try doing anything without opening and closing your fingers. It's very, very difficult, right? So, so when you hear things in the medial 2 digits, ring finger and fifth finger, natural, as John astutely did, to think of an ulnar neuropathy. And the ulnar nerve is one of the few nerves you can touch. You can touch your ulnar nerve here in the medial, just lateral to the medial epicondyle in your elbow. And if you touch it too hard, you get that funny bone sensation of tingling. And if you need to check on an exam, you can see that the tingling will only be distal to the wrist, because although the motor is in the hand, the sensory territory of the ulnar is just distal to the wrist. There's the medial antebrachial cutaneous, which does more proximally, but that's gourmet neuromuscular medicine, right? So natural to think of ulnar, and then this abductor digiti minimi that makes up the hypothenar eminence being atrophied would also make you think about ulnar. And then other things that could fake you out is a lot of this is innervated by C8 as well, but C8 sensory territory does come proximal to the wrist. But we both thought of ulnar, we both heard the word tingling, although it wasn't there, right? Because we were expecting that, and it not being there is quite significant. So John, since you were, as I was, also thinking about tingling, what is the absence of tingling in the presence of these motor features? And I think you said this diagnosis, but just to clarify, if the tingling truly is not there, what does that make you think of?
It definitely makes me key in on a diagnosis of, or early diagnosis of ALS in this case, with the specific motor weakness and the twitching, which I will think of as fasciculations, which is really common as a presenting symptom in ALS. So looking forward to the physical exam to confirm some of that. Yeah, excellent. So, a lot of patients so ALS is motor, the broader umbrella is motor neuron disease, ALS being the most common, stands for amyotrophic lateral sclerosis. In the US, I'm not sure if people call it this elsewhere, but sometimes referred to as Lou Gehrig disease, after a famous baseball player, probably in the 20s or 30s, who tragically had this disease. And so, a lot of these patients will present with something that looks very much like a mononeuropathy. I have a very memorable patient that had a foot drop, and the patient had been sleeping outside and sleeping on the sidewalks and these things, and just seemed like a natural suggestion that he would have compressed his peroneal nerve in the leg and gotten a foot drop. And there was a little bit of weakness more proximally that didn't quite make sense to me, so I thought I would get an EMG because it didn't all quite add up. And the person who did the EMG called me and said, your guy has ALS. And I thought, oh my goodness, he just has a foot drop. Doesn't have anything anywhere else.
And I brought him back, and I had been focused in my busy clinic on the foot drop and getting that sorted out. And I said, do you have any muscle twitching? And he said, oh yeah, what is that? And he took off his shirt, and every muscle was fasciculating all over his chest. So ALS often will begin in one limb and be very progressive in that limb, even though we think of it as a disease that will ultimately involve essentially all of the muscles of the body. It can be quite progressive in one limb, although we might find some other subtle findings elsewhere. But that can occur, a foot drop. And the person who did the EMG was an ALS expert. And I thought, wow, just foot drop. And he said in his clinic, he's meeting patients with ALS whose first symptom was foot drop. So his worry for foot drop, his worry meter is always high, whereas foot drop is usually just from people crossing their legs for too long in the more natural setting, right? So, but when you hear progressive motor, no sensory, no pain, no autonomic features here, that bowel or bladder that might have suggested spinal cord does raise concern for ALS. And you might say, but it's been a year and he doesn't have anything else. Can be. And then over the next year or two, this is unfortunately a disease that I think the average lifespan is probably around 5 years, will become quite progressive and other limbs will become involved. And there may, as John suggested, be subtle signs in the exam already, other limbs are involved. But Vijay is a skilled presenter, and he even told us that someone else thought it could be motor neuron disease. Would he make it that easy for us? So playing morning report roundsmanship. What else should we be thinking about here? Well, the exam is going to be very important, because if really everything does fall into an ulnar distribution here or into a C8 distribution, this is where the nuance of the neuromuscular exam can be very informative. Maybe fortunately this patient does not have ALS, and they have some process impinging on a motor root, or impinging on multiple roots, or impinging on the plexus, and causing a progressive syndrome in the upper extremity. Presumably, if you had something this bad in the plexus or the roots to cause this degree of weakness and disability, we would expect some sensory change to go along with that. So that still would give me pause and make me think about motor neuron disease. So motor neuron disease, just to say, is a broader category, right? ALS is one of the most common motor neuron diseases. There are variants of ALS. Well, variants in how it can present. There's a bibrachial variant where patients present with both arms weak at the beginning, a more bulbar variant with a lot more cranial nerve deficits. There's also progressive lateral sclerosis, which is just upper motor neuron disease. There's progressive muscular atrophy, which is just lower motor neuron disease. And then there's spinal muscular atrophies in children, which are being miraculously treated now with antisense oligonucleotides injected into the CSF. And then there's a condition that's in the differential for ALS, or motor neuron disease in the upper extremities, called Hirayama disease, which is very rare. This is like a neurology boards level disease. I've seen one case where there's progressive atrophy of the upper extremities, often bilateral, but can be asymmetric. And the arms take on a very striking appearance. If you Google this, you'll see there's, I think, a lot of forearm atrophy and less upper extremity. I'm not sure what the exact pattern is, but the arms take on a very striking appearance. And if you do an MRI of these patients thinking of something in the spinal cord, it's often normal, because the pathology is that I don't know if it's the anterior longitudinal ligament or some of the structures around the spinal cord are inappropriately mobile, such that when the person flexes, they're compressing the anterior horn cells of the cord. So you actually have to do an MRI with the patient's neck flexed, and then you'll see this laxity. And I think that's so rare that people don't know the right way to treat it, but often a cervical collar. And the one case I had when I discussed it with some neuromuscular expert colleagues, they said, usually by the time it's diagnosed, surgery is probably not going to help, and just the cervical collar is the best bet. But that's a very rare diagnosis, and I only thought of it because we should be thinking about when we see motor neuron disease affecting one or both arms, it's in the differential. And because also, like I said, just morning report strategy, if someone tells you a diagnosis in the past medical history, then makes you less likely to think, but that's a morning report bias and probably an inappropriate one. So Valeria, I'll ask you to interpret the exam after Vijay presents it to us. So what are you looking for in particular on this exam that might either move you away from this diagnosis of motor neuron disease or toward it?
Yeah, well, I think I would like to confirm the pattern of weakness to see if it's just on the what seems like the ulnar innervation, or if it compromises another part of the hand, or if it's truly asymmetrical. Because I mean, symmetrical it could be more like a polyneuropathy, and then if there's well, reflexes, even though I don't think any reflex, correct me if I'm wrong, but I don't think any reflex will be impaired in case of if it's only the ulnar nerve, and so for its roots. And then sensitivity, if there's loss of it. I'm not really sure what else just in this particular location, but I think those are the main things I will look for.
Yeah, excellent. So the neuromuscular exam of the arm, there's a wonderful video if people want to really learn this well by Michael Charnas, who was one of my professors when I was a resident. You can find on YouTube where he's examining the upper extremity, and for each muscle, he's telling you the muscle, the nerve, and the root that he's examining. He actually has a very interesting clinic where he takes care of musicians with neurological problems and does a very detailed hand exam. He's in Boston at the VA and Brigham and Women's. Michael Charnas. If you want to see his examination of Michael Charnas' examination of the arm, it'll be the first thing that comes up on YouTube. Very good. So right, we'd want to look at, does it fit a distribution? And we don't have time to get into this, would be hours and hours to talk about it. But from some of the stuff I said before, if you know well those 5 nerves and say, does this all fit with ulnar or not? Does this all fit with median or not? At least if you can say yes or no, you can decide, is this a mononeuropathy? Or if it's not, is this a radiculopathy? Well, now does everything fit in C8? No. Does it go into C8 and C7? Could this be a polyradiculopathy? Or too complicated, we have to call it a plexopathy. So even if you just memorize what those 5 nerves you do, you can at least say it's one or more, or it's too many, or it doesn't fit, right? So we'll want to also look at the reflexes. And as you said, we'll want to look at the other limbs. Maybe the patient only notices symptoms in this limb, but we might find abnormalities in other limbs. Valeria, since we're interested in the possibility of ALS here, what things might you observe on the exam in patients with ALS?
Well, if it's only in the atrophy, maybe if it's not just in the hand, see if there's any drooling or compromise of the face as well. So they said medial thinning of forearms and hands. So it is in both arms and hands, the atrophy.
I think we're about to find out.
Yeah, I'm not sure actually. So please.
How about for the reflexes? Do you know, Valeria, what we might see for ALS in the reflexes? It's okay if you don't.
I'm not sure. I think I was listening to one of the past VMRs this morning, and you mentioned that it could be like a mixed. It's one of the differentials of, we had a case of mixed, like upper motor neuron signs, and so maybe hyperreflexia. Upper motor neuron signs mixed with lower motor neuron signs, as we see in this case that has a lot of atrophy.
Brilliant, exactly right, right? So in ALS, it affects upper motor neurons and lower motor neurons together. So it's one of just a few instances where you could see in the same limb atrophy, fasciculations, and brisk reflexes. Or you could see absent reflexes and a Babinski sign or something like that. So a mix of upper and lower, often in the same limb. Not too many things that do that. B12 deficiency can cause a myelopathy and a neuropathy together. So you could get a mix of upper and lower motor neuron signs. Most common in practice is someone has arthritis of the cervical spine with cervical spondylosis, and then some mild cervical myelopathy, and then a diabetic neuropathy. So they have a mix of upper and lower motor neuron signs. And super rare adrenomyeloneuropathy, a variant of adrenoleukodystrophy that has myelopathy and neuropathy, but super rare. Right, so I agree with you, Valeria. We'll be very interested in what's going on in this arm, what's going on elsewhere, and then the reflexes. So Vijay, what did you find when you examined this patient?
So the vitals were normal. Pulse was 74, BP was 120, 80. The temperature was normal, saturation was normal. Coming to systemic examination, The neck length ratio was normal. There was no rashes or any nerve thickenings or any connective tissue features, any facial dysmorphic features. There is no Horner syndrome. Neurological examination, his high mental functions were normal. Cranial nerves were normal. Coming to the motor system examination, cranial nerves, I would just say the jaw jerk was also normal. Motor examination showed a small muscle wasting of the hands with hypotonia, and reflexes where the small muscle wasting was diffuse in both median nerve as well as ulnar nerve territories. Reflexes were preserved, 1 plus all over, mildly diminished, 1 plus all over, biceps, triceps, supinator, knee and ankle. Sensory was normal, cerebellar signs were normal, no other systemic involvement. He had this peculiar pattern of wasting. I'll just share the screen. I think that actually gave us a clue as to what he was having.
You need to, are you a co-host so you can show the, great. And Vijay, as far as his weakness, where was he actually weak?
Yes, sorry, his weakness, the power in the left upper limb was, there was predominant small muscle wasting. Along with that, at the level of wrist, the power was 3/5. At the level of the elbow, both flexion extension was 4/5 and 5/5. In the left upper limb, other limbs were normal.
I see. So weakness gradient, distal the most weak, and then proximally less so, and then no weakness outside of that left arm.
And twitching, there was no fasciculation that we noticed in the entire about 1 to 1.5 hours we examined him. So there is no fasciculations that we noticed.
And then the weakness in the hand, you can sort of see it here a little bit, but did you find that, without telling us how to ask, which muscles were weak in the hand? Are you able to, was it diffusely symmetrically weak in the hand, or was there a focal pattern within the hand?
Yes, so there is, like predominantly there is, it looked like there was more of an ulnar nerve distribution of weakness. So the lumbricals, interosseary, so all of that was weak, with wasting of the thenar as well as hypothenar, both were wasted. I didn't have photos of that actually. So here, some amount of some wasting is seen.
Yeah.
But otherwise, the radial and median were fairly preserved.
Very good. Excellent. Yeah, you can see in the picture.
I think this was something that.
Go ahead. I'm sorry, Vijay. Yeah, go ahead.
Yeah.
Please.
I think this is this one. The examination, I think I'll end it with this.
Very good. Yeah, you can see if you look at the left hand, right, that he's able to, that lumbrical of the index finger is working right, but there's some deficit there. People talk about this hand of benediction or claw hand, and is it median or ulnar? It's actually very confusing. It depends whether the patient's trying to close their hand or open it. It's a very nice paper where someone went and looked at all these old statues. This is up your alley, Valeria, statues and paintings of the hand of benediction, and tried to say theoretically that the priest would be trying to open their hand. And if the problem is with opening, I always forget. Anyway, the USMLE makes a big deal of this, and it's actually much more complicated. If you're trying to close the hand and can't do that well, it's because of the median innervated FDS that's not working. And if you're trying to open the hand and can't do that well, it's because these two lumbricals are not working. So either could give that hand of benediction. Anyway, there's a fun paper on that. And if you haven't seen Valeria's amazing tutorials on sort of how neurology and other medicine is represented in art and sculpture, check those out, and maybe this will be inspiration for another one. Anyway, back to the case here. So Valeria, what are you thinking now, given this exam and then taking a look at the patient here?
Yeah, so it seems like it is quite localized, the atrophy and the weakness. I'm surprised by the reflexes because they are decreased, and so it was not what we were originally expecting. I'm more into so it is only in his left hand, right? The other hand is normal.
Yes.
And yeah, I mean, I think it is just a compromise of the ulnar nerve, as it seems, and so I'm not sure what to do next beyond thinking about mononeuropathy and ALS.
Yeah, great thoughts. So there is certainly ulnar involvement. We see that fourth and fifth finger are not moving as dexterously as the first and well, third and fourth finger, technically, if you don't count the thumb. The digits 1 and 2 seem to be doing more than digits 3 and 4. Vijay did mention that there's atrophy of the thenar eminence. Again, we're getting into very detailed neuromuscular stuff here. So just asking for teaching purposes, don't expect by any means people to know this level of detail. But do you know, Valeria, what innervates the thenar eminence or what muscle that is? It's okay if you don't. Yeah.
I think it was the median. Yeah.
Yeah, that's the abductor pollicis brevis. This looks like a, like a chicken wing you get in the store, right? And that abducts the thumb, which means moves it 90 degrees from the palm, and the thenar eminence is median. So that tells us if there's atrophy there too, that we can't be just ulnar, right? We have to be somehow beyond that, and we're dealing either with two nerves, although we don't hear about median weakness per se, or a root problem that could account, or multiple roots that could account for the hand, so more C7 on the thumb side, C8 on the pinky side, or do we have some particular progressive motor process more proximally? Vijay, in his presentation, it was a very interesting piece of information. He said there's no Horner syndrome. Why would he look for and report on a Horner syndrome in a case of left arm weakness? Any thoughts, Valeria or John?
Maybe the possibility of something compressing the lower roots in the brachial plexus that could lead also to Horner syndrome.
Brilliant, Valeria. Yeah, so that pathway called the oculosympathetic pathway that when affected gives us the rhyming triad of ptosis, meiosis, and hydrosis, starts in the hypothalamus, goes down through the dorsolateral brainstem, and actually goes all the way down the cervical spine to the C8-T1 level before coming back up over the lung apex and then along the carotid artery through the cavernous sinus up to the eye. So by telling us that there isn't a Horner's despite all the C8-T1 ulnar-ish stuff, makes it a little less likely that we're dealing with something kind of around the spinal cord or the plexus kind of lung apex area. Not impossible, but an interesting piece here. So Vijay, you said there's a very interesting pattern of atrophy. I agree with you. Do you want to describe it to us?
So here we can see there is predominant sparing of the brachioradialis here. And if you see here, there is this oblique wasting that is seen here. I think it's more evident here that you see this part of the hand is wasted. And one thing that my neurologist taught me was this. He just saw this hand and he said, this is the diagnosis.
Yeah.
So
yeah, don't say it yet, but yeah. Yeah. Very good. And Valeria, you made an important point here that if this were ALS, motor neuron disease, again, there's multiple motor neuron disease. Usually people mean ALS, but if this is ALS, there should be some upper motor neuron signs there, right? Now, some people would say the reflexes was preserved in an arm that's so weak and wasted that maybe it's inappropriately normal, right? With like, I don't do medicine, but right, endocrinology, when some hormone is way high and the other one is normal, it's inappropriately normal, right? It should have been low, that kind of thing. So are the presence of reflexes inappropriately high, right? When we would expect them to be absent in such a weak, wasted limb, could make us still think about ALS, but no fasciculations and nothing in any other limbs. And this has really been going on for a year, might make ALS a little bit less likely also. And yet we're beyond the ulnar nerve. So any thoughts, Valeria or John? This is a difficult case that we often find in neuromuscular disease where we're looking at the patient and say, this is complicated, right? Gabriella is smiling, right? She's a neurologic practice where you say, this hopefully will be median or ulnar or radial. That's pretty easy. And then you start examining the patient, you say, hold on, I need to pause. What's affected? What's not affected? This isn't making sense. What are some tests we might be able to get to help us out here, Valeria or John?
I think an EMG would help in this case. Try to decipher what kind of muscle loss this is. But is it brachioradialis sparing is what was that the muscle wasting? Oh, I feel like I just listened to a podcast where it said that.
And this might become a podcast where we will say it as well. Very good. Yeah, so the EMG is a test we don't necessarily get too often. And although the EKG and the EEG, you just sort of put them on and watch what happens, right? And interpret it. The EMG is a very active test. So the EMG person will examine the patient and say, huh, looks like there's some median stuff. Let me check the median nerve and let me check the median innervated muscles. Now they can say, what's the Venn diagram of median nerve C6 and C7? Because if I see any C6 or C7 muscles affected, then it's not just median nerve. I have to think more proximally. So each piece of data they get is interpreting the next thing they test to say, is this one nerve, multiple nerves, multiple roots, one root, or plexus problem? So it's really an extension of the physical exam to get at some muscles that might be hard to test and see whether their pattern is suggestive of particular diseases. Good. Any other tests we might that might help us here?
Possibly an MRI.
Yeah, what would you get an MRI of?
I guess in this case, I think the C-spine would be just to check out if there is possibly a very small lesion there that could be causing this.
Yep, I would agree. The C-spine, you can actually get an MRI of the brachial plexus if your radiologists are able to protocol one. Yeah, I think those would be the main tests. I mean, so this looks to me like a disease probably that I had never heard of until someone showed me a picture, just like this one, called Hirayama disease, which we mentioned. Other things to think about that can mimic motor neuron disease. I had a patient who certainly looked to me like they had ALS, but there were some aspects that didn't quite fit. And the patient had known HTLV1 myelopathy. And I learned in that case that HTLV1 can actually rarely cause motor neuron disease. HIV can rarely do it, although it's very uncommon. HIV can do anything in the nervous system. That's a whole nother subject, but other things to think about. Last little point, Vijay mentioned there were no rashes. Now, usually we skip the systemic exam and get right into our neurology. In a patient with weakness in one or more places and skin findings in the place where Vijay works, what was he thinking about by telling us there are no skin findings?
Maybe think, well, Vijay is from India, right? I'm not sure in India, but I was thinking about Lyme and leprosy and also vasculitis maybe. That could also have a skin manifestation.
Good for you. Yeah, so Lyme can cause a polyradiculitis. I don't think there's Lyme in India, but leprosy was the one I was thinking of, where you can see hypopigmented patches, and usually the nerves that are affected are the ones that are closest to the skin, because the bacteria likes cold areas. That's why there are problems in the nose. And he mentioned also no thickened nerves, right, which you can look for as well. In leprosy, often you can see in the neck. And then vasculitis, right? Could this be one or more nerves in a mononeuropathy or mononeuritis multiplex? Keep getting the same nerves in one arm with that, probably a little less likely. So all excellent thoughts, both of you. So Vijay, tell us what you did aside from your attending, coming up, looking at the patient and saying the diagnosis. How did you confirm, and tell us if we're on the right track here with Hirayama disease?
Brilliant. This lab that was normal. I think routine investigations were normal. ANA viral serology, we didn't do a HTLV1. It was not available for us. CPK was mildly elevated, 504. I can share the MRI as well. I think that also gives a clue. So this was a dynamic flexion MRI that we did. This shows a cord atrophy at somewhere at around C6 up to C6, C7 here. This was the normal flexion MRI.
Yeah, fantastic. So if you look at the right here, this is how we usually see the MRI. The patient's head is straight, they're lying down. And on a T2, you should see normal CSF signal on either side of the cord. You see a little disc bulge at C1, 2, 3, 4, 5, C5, C6, but that shouldn't cause all this. And yet on the left, when the patient leans forward, right neck inflection, you lose that entire CSF space, right? So Vijay, you've seen one case, you can count it, and that may be the one and only case you've seen. I've only seen one case, but learned about it like this. Someone showed a case at Morning Report and said, if you see the arms looking like this, it is, and the whole room just looked quietly, silently at the senior attending and said, no idea. And he said, Hirayama disease. And we said, never heard of it. But the key is that you could have a normal MRI, you will not have a normal EMG, but you won't make the diagnosis. So you need that dynamic flexion MRI. I believe this is a sporadic thing. I don't think that we know too much about the genetics of it, but Vijay, I'm sure you learned a lot seeing this case. Do you want to tell us a few things about it, and then we'll have Gabby wrap up with some teaching points.
I just thought I'll share one pearl that like my attending told me regarding the same patient. That hand, he gave one like a reasoning for it. I just thought it would be useful. The reasoning was that, so if we take a nerve as a possibility, so if we have a radial nerve, so if we see that there is a wrist drop and a finger drop, all the fingers has to be dropped. So it cannot be a radial nerve injury. If you're taking an ulnar nerve injury because there is an ulnar nerve pattern, the middle finger that is being absolutely normal and the involvement of the initial 2 digits makes it go against a nerve as well. So the presence of this pattern says it cannot be a nerve, and it is. And we said the motor neuron disease has localization within a segment. So within a segment, there is sublocalization. So it is classical for motor neuron disease. So based on this, we came to the conclusion of Hirayama disease. So this kind of a genetical predisposition where there is a posterior dura that compress over the cord. So usually patients don't really come with weakness, and this weakness usually is non-progressive. It stays for some time and then remains static. And essentially there's no much treatment because by the time they diagnosed, like Aaron said, it's already wasted limb. But only if this weakness remains to continue progressively, then we can remove the dura with surgical excision. But how much of a benefit it does is questionable. We have seen about 3 to 4 patients of Hirayama like this.
Wow.
So one of them required surgery and he improved with surgery. The weakness and all improved with that. So
fantastic. Wow, you've seen 3 of them. My goodness, you have an amazing cohort of patients there. It's very uncommon. I saw one case, not even through my practice. In my prior life, I was a musician, and one of my old piano teachers said he had a student who was carrying this diagnosis and wanted to know if it was right, didn't have insurance, couldn't get into my clinic, so just came to my office and saw him and talked about him with a colleague, and they thought it probably was Hirayama disease. And as you mentioned, I had forgotten this, Vijay, a lot of them progress to a certain point and then it's just static. So it's not clear that doing this huge spinal surgery is going to help them, and they just are put in a neck brace. Well, thank you for bringing this case. I'm sure most people think, well, I'm never going to see a case of Hirayama disease. Why did I spend my morning here? But hopefully you learned some pearls about localization within the upper extremity and the differential diagnosis of motor neuron disease. Brilliant case, Vijay, and brilliantly presented with lots of little things for us to follow, why there was no Horner's, skin patches, etc. And Valeria and John, really brilliant discussion. I'm going to have to duck out and not hear Gabby's wonderful teaching points, but thank you very much, everyone. I will miss you the next, I think, 2 weeks, but then be back after that. So hopefully we'll have some more great cases and folks to volunteer to discuss them. Thank you again, everyone. And again, brilliant case, Vijay, and brilliantly presented. Thank you very much.
Thank you so much, Aaron. I really love today's case. Vijay, I have never seen a case like this before, so it was very didactic case, and I love to see the pictures that you brought. Thank you so much, Vale and John, for the discussion. So we started the case again, talking about the localization versus time course. In this case, we spent most of our discussions talking about the localization, trying to localize between the central versus the peripheral nervous system. Then Vale reminded us of all the motor pathway from beginning in this precentral gyros, arriving to the muscles where the contraction occurs. The first thing we need to do when approaching a patient with weakness is actually differentiate between a true weakness and fatigue or asthenia that can present with weakness as well. Oh, sorry. Oh, I lost the teaching points. Yeah, here. And also it's important to look for associated symptoms like positive pain, tingling, paresthesias that this patient didn't have, or negative symptoms like loss of sensation. And also systemic symptoms like fever and weight loss that usually are present when the patient has asthenia. The time course is also important. So we divide into hyperacute, acute, subacute, and chronic. And this patient had a chronic development of his disease. We also Aaron also taught us the acronym about the radial nerve. So we have to think about radial nerve is the best. V for brachioradialis, E for extensors, S for supinators, and T for triceps. And the brachial plexus, we have to think about the musculocutaneous, axillary, radial, and medial and ulnar nerves. If we see a patient with isolated weakness without tingling and sensory signs, we have to think about ALS, a motor neuron disease, which also presents with isolated muscle weakness. And other differential diagnoses for motor neuron diseases are B12 deficiency, that is also that can also present with upper and lower motor neuron signs, but usually include sensory signs that this patient didn't have. Hirayama disease, which this patient have, and HIV and ATLV1. Thank you so much for the presence, everyone, and I see you in some weeks from now. Bye.